Thanks, Alan. Okay, so I'd like to invite Amy Legg back to the stage. So Amy's going to be running us through the changes to the vancomycin topic.
Finally, what you've all come for, the vancomycin topic. Also, to whoever's doing the technology, it's amazing. Makes it so easy when you haven't got to flick around, so appreciate it. All right, so I think I sort of forced my way onto the agenda for this one. Vancomycin is my favourite drug, and ID doctors always lose a bit of confidence in me when I say that, but it's a great role for a pharmacist, and it's a way you can really make people's lives easier. So I've got a lot of love in my heart for vancomycin. Okay, so there have been a couple of changes to vancomycin, but sort of similar to the penicillin hypersensitivity topic. I think we've now largely just sort of come into line with what people think the best way of dosing and monitoring vancomycin really is. So there are changes to therapeutic guidelines, but they might not be huge changes in your current thinking and hearts. But this is our overall approach to vancomycin dosing and monitoring in adults. And the first sort of decision point is whether or not the patient is critically ill. And the reason that's there is that the critically ill side of the table get a 25 milligram per kilogram loading dose at a max of 3 grams or 2.5 grams if they've got a reduced creatinine clearance. Sorry, this is also predominantly adults. I just saw Asha. I've got a little bit about kids at the end, but yeah, sorry, just to say that now. So creatinine clearance, the maintenance dosing is then based on creatinine clearance with a maximum dose of 2 grams. Contrasting that to the intermittent dosing for non-critically ill patients, we haven't gone with prioritisation of that loading dose. So just to delve a little bit more into that before we come back to the rest of the nomogram, there has been some outcome data related to not using loading doses in patients who are clinically stable. There are some outcome data for patients who have MRSA bacteremia. If they're sick enough, then they'll get the loading dose initially anyway, I guess. So just to say that in the true reading of the guideline, if they're stable, there's no recommendation for a loading dose because of theoretical concerns about the large total daily dose that person receives and a lack of outcome data that it's beneficial for stable patients. But there may be some times when you feel like you want to give a loading dose in patients who are between categories. And then just for practicality, then quite usefully, Therapeutic Guidelines is now giving example dosing tables. So for different weights, what the likely loading dose is going to be. And then additionally, the maintenance dose, what some example regimens are going to be weight banded. Okay. And then the next sort of big change, which I guess you would have seen on the maintenance dose slide, but I went pretty quickly through it, is Therapeutic Guidelines used to recommend a 15 milligram per kilogram per dose once daily, and we've now split that out into a 7.5 milligram per kilogram per dose 12 hourly, which sort of comes to the data from preclinical models, mostly animal models, that have shown that vancomycin dose fractionization does decrease rates of acute kidney injury in mice. So this is the KIM1 concentration, which is kidney injury molecule 1. And the number of times the dose has been fractioned per day along the x-axis there just shows that the kidney injury molecule decreases with increasing number of dose fractionization. Which, even though it doesn't actually support BD dosing, it probably is overall supporting a reduction in Cmax as one of the drivers of acute kidney injury, and that's maybe shown better in these graphs here where the KIM1 has been log transformed, and you can see down the bottom that as the Cmax increases, KIM1 as a marker of tubular injury increases. And so that's why we've gone with the 7.5 milligram per kilogram dose 12 hourly instead of the 15 milligram per kilogram per dose once a day. Also so you can look smart. Now, unsurprisingly, we've gone for a stronger recommendation for vancomycin AUC-based monitoring. Is anyone already routinely doing AUC-based monitoring for vancomycin? Legends. So just just so you've got ammo sort of in your minds, why are we prioritising AUC as area under the curve over a 24-hour period based monitoring? Well, the real reason is for less nephrotoxicity. There have been a heap of systematic reviews and meta-analysis and a heap of observational trials that show that AUC-based monitoring decreases nephrotoxicity. I just thought I would put in the most recent one, which was a paper in the Journal of Clinical Medicine of 2025, and it was a systematic review meta-analysis and showed that AKI incidence was significantly lower in the AUC-based group. Yeah, that doesn't say anything else really that exciting. And the reason that AUC-based dosing has less nephrotoxicity is that it largely results in lower doses because we're directly measuring the AUC as opposed to using a surrogate trough target. So we're essentially just giving less and we're getting less AKI, and we're assured of our target because we're checking the AUC. I haven't actually put it in these slides, I've just realised, but the target AUC that Therapeutic Guidelines is recommending is 400 to 600. And just to be clear, it's not because of an increased effectiveness. It's the same effectiveness with that decreased risk of nephrotoxicity. So again, this is just one of the most recent studies that was a pre-post study looking at trough and AUC blended guidelines. And even though the trough and AUC blended guidelines, which were the post-intervention, the vast majority of people were getting AUC-based therapy, and the trough in that post-period was 10 to 15. And so you can see the first table here has got the differences in dosing. And so in the post-period, the dose is lower, significantly different. And then just to show some of the outcome data in the table underneath it, you can see that the third and fourth lines there, the length of hospital stay and in-hospital mortality rates are no different. The odds ratio is no different. But the acute kidney injury is significantly different at the bottom there, and that's probably driven by a reduction in vancomycin dose purely by using AUC-based monitoring. So AUC is not widely available, or it is widely available, it's not maybe widely done. And so the other thing we have done is we've gone with a trough concentration reduction. And we can fight about that at the end, maybe. So we're heavily prioritising AUC-based monitoring in someone where you absolutely have to know that you're achieving your target. And then we are allowing in stable patients a trough concentration between 10 to 15. So the reduction in acute kidney injury is when a trough concentration of 15 to 20 is compared with an AUC-based monitoring regimen. Probably the nephrotoxicity with a 10 to 15 trough concentration is the same as an AUC of 400 to 600 because the majority of people with an AUC of 400 to 600 get a trough of 10 to 15. I'm having a good time. And I just wanted to talk about how we even got to 15 to 20. I'm not sure if Prof Moulds is still in the room, but in 2010 at ABG 14, we had 15 plus or minus 3. Who remembers 15 plus or minus 3? Yeah. Oh, probably was right. And then in 2014, and this... Professor Rob Moulds was the chair of this group, and I'm sure he remembers the meeting where they decided to switch from 15 plus or minus 3 to 15 to 20, which was really driven by the fact that you're assured of an AUC of 400 if your trough concentration is above 15, and we just didn't appreciate the nephrotoxicity that came with that at the time. But I remember I was an editor at the time of Therapeutic Guidelines, not an expert, and I remember it being Jess was there, a very tense meeting. And even at that time, the group left 10 to 14 as a recommendation for those who are clinically improving. But for whatever reason, it's not really translated. Like, people really have in their heads to aim for 15 to 20, but the 10 to 14 has actually been there for a long time. And then in antibiotic 16, essentially it remained the same with the recommendations of 15 to 20 or 10 to 14 if clinically improving. So not everyone at a trough concentration of 10 to 15 will achieve an AUC of 400. that's the big thing you have to think about if you're going to allow a trough of 10 to 15. So the AUC prioritisation table is our recommendations for the people who are either at high risk of nephrotoxicity, who will hugely benefit from AUC-based monitoring as a decreased insult to their kidneys, or the people who you do not think it's safe to guess what their AUC would be now that we've moved it to a lower trough target where an AUC of 400 is not guaranteed, but highly likely. So the patients who are in the AUC prioritisation table are critically ill, severe necrotising or deep-seated infections, have suspected or confirmed Staph aureus bacteremia, and then obesity, augmented renal clearance, not augmented renal clearance, but obesity and are at high risk of acute kidney injury is really because you can get away with a lot lower doses in those groups if you actually just check the AUC, and so they'll be at decreased risk of nephrotoxicity as opposed to maybe not being part of that worrisome subtherapeutic group. Okay, so I'll quickly go through an example. This is a 25-year-old with an MRSA bacteremia who was 90 kilos, 190 centimetres, and a creatinine of 45. So those sort of creatinines in someone with a normal to high body weight do make me a little bit suspicious of very good renal clearance. So they got a 3-gram loading dose, and then they went to 2.25 grams, excuse that typo there, 2.25 grams, 12 hourly, and they had a TDM of 11, and the question was, what do we increase to? I try very hard not to avoid going above a 2-gram dose before switching to 8 hourly, but of course with a concentration of 11, the group wanted to go to 2.5 grams BD. Where am I going with this? Anyway, so we plotted this. This is again in TDMX with the concentration there, and of course the AUC at 48 hours was actually 502 milligram hour per litre, and so no dose increase was needed, but we were able to use this to switch them to an 8-hourly regimen that got below the 2-gram intermittent dose and actually got us a trough more towards 15 so that when they rechecked they would be happy. So just a couple of quick sort of Vanc AUC pearls. AUC is a marker of total exposure. So once you get to the same daily dose, you're essentially going to give the patient the same AUC. So this hopefully is not too confusing, but this is actually, we're working on a Vanc dosing calculator with CSIRO. And these, if you look at the AUC 24 column, it's all essentially the same number. And it's because the doses are all 2 grams a day, just at slightly different dosing frequencies and durations. And then right at the end, you can see the troughs are quite different. Because of course, if you give 2 grams, the bottom line, if you give 2 grams over 4 hours once a day, you're going to have a lower trough than if you're giving 500 milligrams 6 hourly. Does that make sense? Yeah. Come on, Amy. So it's really about, once you've realised what total daily dose you need, you can be quite creative with your vancomycin doses to get the trough you want or the peak you want. Why would you want a peak anyway? Okay, let's move on. The other thing that we weren't able to fully reconcile before the guidelines went live is exactly what the best concentration is for your AUC calculations. And so some of the people that might be doing this might have already dealt with this. Trough concentrations may not be the ideal time point for AUC calculations. And if this graph is all the different recommendations from the different models based on that patient I had that was 25 with an MRSA bacteremia, because essentially you can anchor your concentration time profile around a trough, but it doesn't tell you really anything about the gradient of the line. And so some centres who've implemented AUC-based dosing are doing mid-levels because then you get a bit more information about what the likely clearance is sort of as you're coming down the concentration time curve. But there's a med safety risk with that in that if that is interpreted as a trough for people who are still using trough-based monitoring, that will look high and they might falsely get a dose decrease. So for now, we've just said that the optimal dosing, the optimal timing for a TDM for vancomycin AUC remains unknown. But this paper by Winsher, who's the developer of TDMX, proposed that maybe a 2 to 6.5 hour post-dose sample was the best for predictive ability, but the improvement was about a 2% increase in predictive ability. So we've left it a bit open, and I think at my site we'll probably start with troughs, and then once we've got people a bit more socialised to AUCs, maybe we'll just go to doing the Vanc level with the morning bloods. Now, one of the questions I get asked all the time is how can you recommend AUC-based monitoring outside of MRSA bacteremia? And I think this is a common misconception because the AUC-based monitoring is so heavily pushed from IDSA through their MRSA guideline that it only relates to that. But actually there's quite a bit of data now about AUC to MIC targets in other gram-positives that vancomycin is used for. So we can see here that for enterococcal infections, there's been at least 3 studies that support around 400 as a target. There's quite a few papers for quaquelectin-sensitive staphylococci, particularly in kids. And then there's the multi-resistant cons paper at the bottom there. And then even for streptococcal infections, it was about 330, an AUC below 330 was associated with a decrease in clinical success. So I do think we can use the 400 to 600 outside of just MRSA infections. I think for the gram-positives, there's probably pretty similarity around that target. Maybe, if you're doing it for Elizabeth Kingia, good luck to you. The other thing that comes up all the time, we have maybe stepped back a little bit in this edition of the guidelines, and we're not giving a lot of specific information about what to do for CNS infections. So we've done that great thing where we've just said to call the experts, so they can just call you guys. I think the thing about CNS infections is now that we've got these, deep-seated fears about high doses of vancomycin, it's hard to routinely recommend them. But, I do think for CNS infections, we don't have an AUC to MIC target. You probably need prolonged high concentrations of vancomycin to ensure you have penetration into the CNS. And traditionally what we have done, which has worked pretty well, is to give a loading dose and then to essentially transition to a continuous infusion if you can't achieve a trough concentration around 20 with intermittent dosing. And the exposures with a trough concentration around 20 for intermittent dosing are really high. And so switching to a continuous infusion and giving that prolonged high dose can be really beneficial. But unfortunately for the guideline, we just suggest that high prolonged exposures are needed and we don't give a lot of specifics. There is a new section for vancomycin in hemodialysis. And again, it's essentially just a flag that it's here. There's been some amazing work coming out of Alice Springs, and Danny Sy is about to publish, I think, 2 or 3 papers around vancomycin dosing and hemodialysis. I think he's done it in combination with the Darwin group. And, that wasn't maybe ready for this edition, but I think the Alice Springs and Northern Territory group essentially are going to revolutionise this content for the next version. And then just to say, we're very ably supported by some paediatric colleagues, and some of the highlights for the vancomycin in young infants and children were that loading doses, there's limited data to support loading doses in children, so they weren't routinely recommended. Maybe recommended in some situations. Individualised dosing is preferred, and I just wanted to highlight the kids calc that I know a lot of people use for vancomycin dosing. For 3 months or older, 6-hourly dosing is preferred, and AUC-based monitoring is recommended. So just to finish, huge thanks to the TG expert group and the TG staff.
Alan has a question.
Wouldn't this be a whole lot easier if it was just continuous infusions? It'd be really easy to calculate an AUC.
Yeah.
Max.
Yeah, it would be. I think, I'm not anti-continuous infusions, and people do say this a lot. I'd love to get a nursing panel because I feel like it's not me that's saying no. I don't know if anyone is saying no. We recommend continuous infusions. We've just written an article with Australian Prescriber where we say calculation of AUC is much easier from a continuous infusion. I think it's just those practical limitations about being hooked up to a line. And I wonder if, because I just wonder if maybe we haven't got the same body of evidence for continuous infusion that we have for the 12-hourly, that's sort of, you know, we're making these really small incremental changes as opposed to a wholesale big change and just recommending everyone goes on continuous infusions. Yeah, it would be a whole lot easier.
Thanks, Amy.
Great.